surgeons, you open up the patient and you're going to repair, as you can see here, the laceration, the puncture laceration of the aorta. It takes just a puncture to do that. This was a very experienced surgeon that ran into this injury. So experience sometimes makes you too comfortable. You have to be careful when you're placing your trocar. Really just pay attention to that. Don't talk to the cute nurse that's next to you. Just focus on what you're doing, because for a simple cholecystectomy, you can run into this open laparotomy and have this kind of complication. So really pay attention and do not hesitate to convert if you have this kind of situation. Always look immediately below your optical port before doing anything else. And I would suggest look even before connecting the CO2, because if by any chance you're injured a vessel, you can have an embolism if you don't, if you connect the CO2 directly into a major vessel. So go step by step. Another very experienced surgeon with a beautiful colonoscopy that you can see here. So the access in this case was intraluminal, not in the peritoneal cavity, but in the lumen of the colon. So what you do if you have this, well, you pull back your port, you position your other trocars, and if it is accessible from you just go ahead and repair immediately the injury, and then you can go ahead and do your keep working. This can happen when you have a lot of adhesion. So if you're not comfortable laparoscopically and you don't have access, convert the patient and repair. So the first thing is do no harm to your patient. So there is no failure in conversion in this kind of scenario. Is there a risk with access? Yes, because you have from 2 to 7% of mortality. It's not morbidity, it's mortality related to the first step of the operation, which is access. And this is particularly so in difficult patients, namely obese patients, patients who had previous surgery. Really, it is important what kind of trocar you're using. Are you using blunted trocar? Are you using sharp tip trocars with blades? And the technique of introduction of your trocar, not only which device you're using, but how you're introducing the trocar in the peritoneal cavity. So we're going to discuss several accesses because not only you can need to access the peritoneal cavity, but sometimes you need to access also the retroperitoneum in order to perform operations such as inguinal hernia, pancreatectomy, adrenalectomy. And this is an access that we use for the TAP procedure for inguinal hernia repair. And you can see here that we are accessing the cavity between the fascia transversalis anteriorly, the peritoneum posteriorly, and the iliac fascia laterally. And this is something that is done very commonly here and will allow you to perform your operation without transpassing the peritoneal cavity. This is particularly interesting for retroperitoneal structure, for instance, for adrenal 2, because you're directly going to access the organ of interest. In this case, is a TEP procedure, is a hernia. Once you have done your initial incision, you're sliding through the fascia and trying to put your best effort in order to preserve the peritoneum. This is done here with an optical port, which is something very useful in this scenario. It's a blunt dissection in combination with CO2 insufflation. We're using the camera to get the good orientation. You can see the muscle right on the side, and it's a pretty bloodless dissection and an area if you do it under vision and slowly. And you just slide onto the peritoneum. Especially at the beginning or in some complex patients, you can run into tears of the peritoneum. What you do in that case, you can place a varus needle, for instance, at the palmar point to deflate the peritoneal cavity, or you can put a trocar to do that if you have a lot of CO2 that went into the peritoneal cavity that is compressing your retroperitoneal space, or in the worst case scenario, you just convert a TEP procedure to a TAP procedure. So that's not a big deal. Once again, it's very important that you are familiar with this bug space anatomy for TAP procedure, and that you do everything under vision and you're using the camera to guide your dissection, as you see here, all the way to the pelvis, and that CO2 is also helping you accommodate the spacing. Once your first trocar is placed, you can go ahead and place your other trocars. You could also use a balloon. I'm not a big fan of the balloon in general because it's an uncontrolled disruption of tissue, creates a lot of bleeding, and when you have bleeding in such a limited space, it's much more complex to understand the anatomy and to identify the different structure. But this is something we are not doing at our institution. This is just to let you know that there are some devices that were made in order to create the space at this level. As I mentioned before, another use of retroperitoneal surgery is that of adrenalectomy. And very similarly to what you have seen before, you create a space with the initial trocar, and then you put your finger and you place the other two trocars. And here, very importantly, the use of CO2. We use a very high level of CO2 insufflation. We can go up to 18, 20 millimeters of mercury because it's very well tolerated by the patients and it's not going to do any harm. And you can approach the pancreas, you can approach the kidney, but mainly it is used for adrenalectomy. So what kind of gas? We access the cavity, we need to create some space, and we do that using some gas, and typically CO2 is the gas that we use. Why? Because the ideal gas should be cheap, should be colorless, non-inflammable, of course. You have to avoid any explosion. Has to be also easily evacuated and has to be, it's a no-brainer, non-toxic for you and for the patient. CO2 is the most commonly used gas. Why? Because it does comply to all the characteristics that I mentioned before, but also because it's easily absorbed, which is a good thing and a bad thing. It's a good thing because is excreted by the lungs, but it can. You have to be careful also to accommodate the pressure so that you don't create a hypercapnia in the patient, and that you monitor the cardiac and ventilatory parameters of that patient, because you can create hypercapnia and acidosis, which do have a direct and an indirect effect on the cardiovascular system. A direct effect because you can have a decreased cardiac contractility related to acidosis, you can have arrhythmias, you can have vasodilation, which can influence also the blood pressure of the patient and the cardiovascular system as a whole, and you have indirect action through the sympathetic adrenal stimulation with vasoconstriction tachycardia. And of course, all of this is more present and has to be also analyzed according to and tuned, I would say, by the anesthesiologist according to the duration of your surgery. CO2 has not only mechanical effect, but also biological effect. We mentioned some of them, but what is really important is that at the beginning of insufflation and also at the end of the insufflation, you have to go really slowly. Why? Because the peritoneum is an organ. It's not just a tiny little sheet of tissue. It's an organ that can have a deep impact on physiology. So the distension of the peritoneum itself has to be really slow. So you want to avoid any rapid distension due to insufflation. You really have to tune it. Usually it's done automatically during insufflation, but you have to make sure that you're really paying attention at this first step of the operation. Because when you're increasing the intraperitoneal pressure, of course, you're reducing the lung capacity, you're increasing the airway resistance and the airway pressure as a whole, you're decreasing the pulmonary compliance, and you have compression of the basis of the lung, also because, of course, you have the diaphragm that is pushed towards the lungs themselves, so you are reducing the total capacity of the chest as a whole. Just to summarize for you, there are some pros and cons of the different positioning that we can use for the patient. If there is a take-home message, and if I can make this very, very easy for you to understand, of course, when the patient is head down, you have a better cardiovascular control of the patient. When the patient is head up, you have a better ventilation, but a worse, I would say, a more difficult control on the cardiovascular aspects for all the reasons that we have discussed so far. More and more we're using low peritoneal pressure, what is called low impact laparoscopy. Low impact laparoscopy doesn't only mean reducing the size of the trocars, but also reducing the CO2 pressure, insufflation pressure, and this is something that has very positive consequences on the pain the patients can experience after the operation, and as a whole of the experience, physiologic experience of the operation of the patients. Be aware that although we are hyper-technological, we have beautiful monitoring of the patient, we take all the precautions to prevent this event, you still can have gas embolism. It is rare, but it's still there, and you have to pay attention to it, especially if you're doing some procedure, for instance, TATME, transanal transrectal surgery. There has been some cases because of constant insufflation in this new plane of dissection for surgeons, I would say. You have to suspect it if the patient is collapsing on the table. You have to talk immediately to your anesthesiologist. Remember that the CO2 embolism is directly related to the amount of CO2 that you're injecting and the rate of injection, so to your pressure and your flow rate. And if you have a drop in the end-tidal CO2 respiratory, from a respiratory point of view, following insufflation. So what you do, you stop insufflating immediately. That's the first thing. It's a no-brainer. So you give high flow oxygen to the patient. You change the patient to the left decubitus and Trendelenburg. You hydrate well the patient to wash it out. And you go from through resuscitation and hyperbaric oxygen therapy. Some contraindication to laparoscopy, they're still there. There are less and less today. We are more and more comfortable with laparoscopy, but there are definitely some anatomical limitation. If you have a frozen abdomen, there is no way you can entry. And a frozen abdomen today for me is a patient who had multiple surgery, diffuse peritonitis, and I cannot really even put a port there. I would try, but I wouldn't insist if I see that they have no space. And then there are also some physiologic limitation. Once again, those are rare today, but you can have some pulmonary contraindication. You can have some cardiac and circular contraindication. And also don't forget that you can have some neurological contraindication due to intracranial pressure. If the patient typically, you know this better than me, is in shock, in septic shock, or totally hypovolemic shock, the anesthesiologist will tell you don't do laparoscopy, but privilege a laparotomy approach. So we have our beautiful pneumoperitoneum. Now we're going to discuss trocars. There are multiple trocars, different in diameter, in penetration tip, captating, bladed trocars, blunt tip, radially expanding trocar. And you can pick and choose from different brands, different companies. We also have needle trocars with traction sheets that are supposed to reduce the likelihood of having an incisional hernia. As I mentioned before, and you saw it in the previous videos, you have optical trocars. You have balloon trocars that are very useful. In some cases, we use them typically for intragastric surgery when we want to do laparoscopy within the gastric cavity, because of course they hold very well and they can approximate two tissues together. There are trocars that are meant for single port surgery or single incision surgery. This is something I don't practice every day, but just for you to know that they exist. And then you have hand-assisted devices that are very popular in the United States, much less popular in Europe and in Asia. What are the risks with the positioning of the trocar? We saw it a little bit with the first trocar, but the first videos that I showed you, but I just want to stress that there is always a risk of vascular injuries. You also can have injuries to the bowel, and then of course later on, or even in the immediate postoperative period, you can have the risk of incision hernia. Anything that is bigger than 5 centimeters should be closed and should be closed properly. What are the causes of how big is this a problem? It is a big problem because when you look at the causes of malpractice and injuries, trocar insertion counts for 31% of those. You can have fatal injuries with the first trocar that you're inserting, and mainly those are related to vascular injuries, but you could also have non-fatal injuries that can be very detrimental for the patient, very dangerous. If you're injuring the bowel and you don't recognize that, and you leave the patient with an open jejunum or a small bowel injury or colonic injury, this is something that can turn into peritonitis and can turn into a nightmare for you and for your patient. So always check every time that you're placing the first port and then introduce the other ports under vision. Shield trocar and optical trocars seems to have a reduced fatal injury, so they are safer, especially if you're starting your practice. But what is really going to make the difference is the way you manipulate your trocars and the way you introduce your trocars. I always tell my residents, don't make tiny incision if you're using a blinded technique with a Varus needle. You have to make a comfortable entry for the trocar. Why? Because that's going to decrease the amount of force that is required. You always have to control the entry using your left hand while you're introducing and pushing and turning with your right hand. It's not a stabbing that we're doing, it's a control introduction with a 45-degree angle, a control with your left hand. And then once the first port is placed, always look down. Then you can connect your CO2, and all the other trocars should be placed under vision, under direct vision, and illuminating the abdominal wall whenever possible in order to spare any vessel that may run into the abdominal wall. You're supposed to know where the epigastric arteries run, but do the transillumination systematically. It will be very useful for you to prevent injuries. The force, once again, generated by the trocar is very important. It's something that you need to learn how to control. Doesn't matter if you have a 5 or a 10 millimeter trocar, do it under vision, and you could also increase pushing on the contralateral side of the patient, the distance from the abdominal wall to the internal organs, and you can shift the area of higher pressure using this maneuver in order to increase the safety. You can also control with your other instruments, as you can see here, the introduction of the penetrating tip of the trocar. So these are all things that will help you to start well your surgery without the risk of injury. Here is some other example of trocar introduction. You can see here. This is if I'm not wrong, for a misinfundification. So careful, because you can also injure the liver. This. So everything always has to be done perfectly under vision. Use a 30-degree camera because it's going to serve you well. This is a case that I want to show you because it was a live surgery performed not even a year ago here in our institution by a very, very experienced surgeon. And the first trocar he placed, he made an injury right into the mesentery. And what you have to do in this kind of scenario is really take care of it immediately, control it, hack it, and before you keep going with your surgery. Once you have obtained a good control, you can go back and finish your surgery, and then of course afterwards check it again. So once again, experience doesn't prevent injuries, and you have to be careful with every single patient because this kind of complication can happen to anybody. And think again, when you're placing a port, have this visual graph in your mind. The force that you're generating has to go through two structures. One is the fascia, and then you have the peritoneum. And you have a big loss of resistance when you are in the peritoneal cavity. And that is why your left hand is going to control your right hand. It's going to prevent your right hand from going through structures that are not meant to be transversed. Vascular injuries are the thing you have to watch for, in particular the aortic bifurcation and the common iliac vessels. This is something very important for the residents to know because one of the first surgery that you're going to do by yourself is appendectomy, and appendectomy has a higher rate of iliac injury, so be careful. Should we use blunt-bladed chokers? I really don't like blunt chokers, I have to be totally honest with you, because especially when I see them in the hands of junior surgeons, I see so much pressure. You can really see the person pushing with so much force on the abdominal wall that I think that that is more dangerous to me than a bladed choker. So if you're using blunt chokers, make a bigger skin incision and really be careful with your force, because they might be better in terms of controlling wall bleeding, but if you don't control the force, you can have some injuries. The angle of the choker is also very important. Make sure that you're orienting your choker towards the area that you're going to tackle, and then according also with the patient anatomy. So although we have schematics for choker positioning that are pretty standardized per operation, the anatomy of the patient is something that you have to take into consideration because of adherences, because of big livers, or because of obesity. This is something that you have to take into account in order to triangulate perfect your action. If you don't have triangulation, you're basically handicapped for your operation. So really, you want a camera in the middle. You want your hands at the side, and your eyes and your head are in the middle, and then you have your arms sideways. That's the idea of laparoscopy. Remember also that you have to adapt your choker position to your morphology. I use a more narrow choker position because of my morphology. If you are big and bulky, of course, you're going to be wider. Take into consideration that if you're more narrow, you're going to have more conflict in between your instruments. And if you go wider, you won't have conflict, but you will fatigue. So those are things that you have to remember. A rule of thumb that is extremely useful is use your hand or your wrist in order to space the working choker from the camera. Usually it's 8 to 10 centimeter, the space that you want to have from your camera to your working port. And this is something that really reproduces well the width of your hand or your fist of the distance between your shoulders, so that you can be comfortable. Before positioning of the chokers, beware of the epigastric vessel. Now this is something that is really a pain. When you run into a bleeding at the beginning of the operation or even at the end of the operation on the epigastric vessels, it's something that you can spend 1 hour trying to control. So really be careful. You can have a lot of bleeding from the epigastric vessel. It's a known cause of reoperation due to hemoperitoneum after surgery. Take care of dealing with it immediately. You can try bipolar coagulation from another port. You can try stitching using a Percy needle. In the worst case scenario, if the patient, you could also try embolization. But of course, this is in the postoperative period. Keep in mind that this can be avoided with a good understanding of the anatomy, and that you need to fix it right away. Always remove chokers on vision because of the risk of bleeding. deflate the pneumoperitoneum. Now with the COVID crisis, suction out all the pneumoperitoneum before taking out your trocars and the vision. Suture all the incisions that are larger than 5 millimeter, because you do have the risk of incisional hernia. This is how we remove the trocar under control. So we just gently slide the trocar off the instruments. This keeps the access there in case we want to put the trocar back in order to coagulate. Always remove also the optical trocar under vision. Just pulling the camera back. This is something very easy to do. This is another example of epigastric injury, this epigastric artery injury, and how to control it. Once again, it can be pretty messy, so do that under control. You can close your trocar using a direct access, or you can use the endoclose or the burst needle. This is really up to you, and it's a matter of how familiar you are with this device. If you use this device, make sure you don't stick it in the bowel, and that you really put it at the 4 different quadrants of the trocar so that you can have a nice purse ring suture and a very nice and secure closure. Closure is important, and I'm going to use one of my last slides. This is a case of a, I hope that is working, of a case of a patient who had pain and vomiting after surgery. You can see very well from the CT scan what the problem is. You have a hernia, incision hernia that is there, and you have the bowel that with initial signs of suffering and injury that is migrated into the optical port. So close and close well is really the recommendation. And whenever your patient has something wrong after laparoscopy, think about it, because this is something that might happen, especially in obese patients. So, some take-home message to conclude the lecture. Open laparoscopic technique is recommended to access the peritoneal cavity. It's a very elegant technique. You can have nice scars. I pay very much attention to the aesthetics whenever I operate, and I can tell you that it's better to have a couple of millimeters more with not too much pressure due to the trocar onto the skin than having this tiny incision with all edematous and black at the end of the surgery that will give you a horrible scar. So start with this technique, especially if you are resident. Be aware of the effect of CO2. Physiology is important. You are responsible. You have to know exactly what CO2 can do to your patient. Increased intraperitoneal pressure does have effect on the cardiovascular system, on the respiratory system, and in general on the renal system too. Be aware of gas embolism. It's a rare event, but you have to know what to do and how to react to this event should it happen. Introduce your trocar correctly. Use your 2 hands, control the force, control the angle, and always look down and check if you made any injury before going ahead. And remember that it really doesn't matter what kind of trocar you're using. There is no safe tip trocar. I'm happy to take questions if you have any. Thank you very much for your attention.
Okay, so thank you, Professor Peretta. As for the nice lectures, 3 a long series of lectures. There's a question about if the patient develops subcutaneous emphysema in the middle of operation, and say like the chest wall and up to the neck, the face is all blown up. What should you do?
Well, really you have to check whether your insufflation trocar is correctly positioned, because you can have CO2 diffusion into the abdominal wall and to the chest. CO2 is very volatile, so if your trocar, you check your trocars, if they're properly inserted and the patient is stable from a cardiovascular and respiratory point of view, you may want to decrease your CO2 insufflation, but there is subcutaneous emphysema. I wouldn't think that it's something that would have you convert or stop your operation.
请问我们现场有没有什么问题呢？对于刚刚的 trocar 啊，跟 operating room 这些 setup。这是一个很小的班，我们可以那个叫随时问问题。So I have one question. Some surgeons like to stand on the one side of the patient, and that will provide better ergonomic for the surgeon because the hands are closer together, as opposed to the camera being in the middle and the trocar on either side of the camera, and that you have better triangulation, but your arms are more wide apart, and you will have a worse ergonomic and less and more shoulder pain potentially after the surgery. What's your take on that? Like it's like a French position versus like Asian position debate.
I trained both in Europe and in the United States, and I'll give you a basic example: cholecystectomy. I was used to the American-style cholecystectomy, in which you're standing on the left side of the patient and not in between the legs. I have to say that for me it's much more comfortable to have the French position and to stay in between the legs. I like, for me, it gives me better triangulation and more direct access. Then it really depends what you're doing. And what is I know that for gastrectomy in Asia, you're standing on the right side of the patient, and I've seen it done beautifully. I feel that I lose a triangulation if I do that, but I think mainly it's a matter of habit. I think both are definitely possible and can be learned. I think if you have to suture, I would privilege triangulation because I know that for some gastrectomy, if we look at the beautiful operations of our Japanese or Korean colleagues, they very rarely suture. They mainly use taper. If you're using taper, it doesn't matter where you're sitting. If you want to suture a lot, you have to be comfortable, and you are more comfortable when you are in between the legs because you have more triangulation.
Okay. Is there any other questions? Okay. Okay. So I think there's no questions at this point. So thank you very much, Professor Beretta, and it's a pleasure seeing you again. And I think we have you back with us again in the next few days. Okay.
Perfect.
So, okay, so have a good day.
Have a good evening,
Yes.
and the rest of the day, and I'll see you tomorrow, on Monday. Not tomorrow, but on Monday.
Okay, bye. Bye-bye. Okay. How? Okay, so next we welcome Dr. Ong. Dr. Ong, are you there?
Yes, I'm here, Wayne. How are you?
Okay, thank you for joining us. Dr. Raymond Ong is the Director of Surgery and FEU from Manila, Philippines. And it's one of the top university in Philippines, and he has come many times to our course to teach, and is an excellent teacher. And one of, I think, the most skilled surgeon in Philippines. And so we're happy to have you talk to us about
placement. Others use single incision. This is our standard technique for all our appendectomy, whether uncomplicated or complicated. So it is important that you do not touch directly the appendix. Use bipolar or advanced bipolar or ultrasonic device. Always stay close to the appendix. Check for the cecum or the base always. Identify if you are near the base of the appendix, because the part of the cecum in that area is thin. Closure of the appendiceal stamp has been studied vastly, and different closure approaches has been a challenge, especially for complicated appendicitis. So you're seeing here the use of a stapler, because this is a 40-year-old female who had a TB, tuberculosis of the appendix. So that's why we're getting some part of the cecum together with the appendix. So these are the several studies on the stump closure as shown. And all of these studies showed no significant difference as to its complications intra-op and post-operatively. So whatever stump closure that suits you, whatever makes you feel happy, or whatever technique you are used or comfortable with, then there's no difference on the different techniques. So in our training program, we asked our fellows to do an intracorporeal tying of the base using an absorbable suture. So this is to practice them with bimanual dexterity and intracorporeal tying. Okay, sorry, my laptop hand. Okay, so during a laparoscopy, once you enter the abdomen, you go around and check for any fluid collection. So this is a ruptured appendicitis with a phlegmon mass, and as you can see, we don't infuse water, we don't infuse saline, we suction all the visible abscess, the visible pus. Then we dissect away the surrounding structures, use the ideal instruments. So we just suck if you see secretions. So if the base is not clear enough, you need to dissect further the cecum and liberate the cecum. You can see some abscess collection behind the cecum. So you use the suction. It can help you clear your field. Use advanced energy device. So combination of blunt and energy device dissection. Again, the goal is to identify the base. So liberating the cecum would give you a better view of the entire cecum. And your goal is to totally secure that base. So this time we use a bigger needle, a bigger suture, so we can go around that appendix on the other side this way. And we go above the area of perforation. So usually we just put one suture, and after which that's the time we continue decontaminating the peritoneal cavity. So not all uncomplicated appendicitis have localized infection. So in this case, this is a suppurative appendicitis, but as you can see, the fluid purulent abscess collection is from the pelvis up to the right upper quadrant. Interloop abscesses must be cleared always. So these are some problems post-op with prolonged ill use and reasons for reoperation because of persistent abdominal pain, and fluid collection or abscess collection. So you have to aspirate all visible abscesses. You manipulate the bowel. You turn the patient left and right, head down, and then run the bowel, use the pelvic cavity, use the Morrison's pouch, do by manual manipulation, and wash all the cavities. So do you put drains routinely in your appendectomies? So up to this time, the use of routine drain post-appendectomy is still a controversial debate, but most studies recommend against using it. Even in the WSES 2020 guidelines, drains are not recommended for both pedia and adult patients. But in our local study, this was done years ago, in 61% of complicated appendicitis, all patients were drained. And we found out for complicated appendicitis, most patients first 24 hours have significant drainage. We noted return of bowel function in 24 to 48 hours. In all our uncomplicated appendicitis, we do not use drains. So we now go to emergency gastric perforation. Okay. So perforated ulcer disease. Okay, my laptop hand. Okay. So despite the reduction in the incidence of the rates of hospital admission and mortality over the past 30 years, the pathology was traditionally due to hyperacid secretion and the dietary factors and stress. However, the increasing incidence of Helicobacter pylori, the extensive use of NSAIDs, and the increase in the alcohol and smoking abuse have changed the epidemiology of this disease. Complications are still encountered in 10 to 20% of all these patients. Although perforation is less common, with the perforation bleeding ratio approximately of 1:6, it is the most common indication for emergency operation and causes about 40% of all ulcer-related deaths. This will be the scope of my discussion, and I will focus on the following. Non-operative management of perforated peptic ulcer is being done. So you have to put your patient in NGT, decompression, anti-secretory, antibiotics, repeated physical examination, follow-up endoscopy 4 to 6 weeks after once the patient has improved. Non-operative management of perforated peptic ulcer disease was based on the premise that the small perforations seals on its own. Non-operative management of small perforation is attractive as it avoids surgery, and its resultant would be like wound-related complications. Most perforated ulcer actually cannot be managed non-operatively. Patient must not have any signs of peritonitis. He has to have a normal vital sign, stable patient with radiologically undetected leak, meaning ulcer has sealed as confirmed by a water-soluble contrast study. Surgeons need to have repeated physical exam, his readiness to operate anytime when the patient shows signs of peritonitis. In the event that there is a free leak of contrast, even in a stable patient, surgery is required. Mortality increases in every hour of delay to surgery. Therefore, patients must be carefully selected. Bach et al. In more than 2,600 cases have shown that every hour of delay from the admission to surgery was associated with an adjusted 2.4% decrease probability of survival compared with the previous hour. Elderly patients may experience paradoxically higher mortality if non-operative management fails. Therefore, caution is advised in this age group. Non-operative management has shown to be effective. However, the uncertainty in the diagnosis, the potential delay for the treatment in non-responders, and the unresponse in elderly patients makes it difficult to be applied to all clinical situations. Okay, so surgery, either open or laparoscopic, is a good option. All patients presenting with acute abdomen with the possibility of perforated peptic ulcer must undergo surgery as soon as possible, especially patients older than 70 years old. Considering of the approach is very important. Open versus laparoscopy. It is very characteristic of the management of perforated peptic ulcer disease to consider the status of the patient during the time of surgery, because it has a higher operative risk for patients who are unstable and those expertise and inadequate facility is unavailable. For stable, low-risk patient, we suggest a laparoscopic approach. An open approach is recommended in the absence of appropriate laparoscopic skills and equipment, and in unstable, high-risk patient. Boy's scoring system highlights the evaluation of risk factors and predicting morbidity and the surgical outcome. The duration of perforation, more than 24 hours or less, the presence of concomitant comorbidities, the present shock, systolic blood pressure less than 90 millimeters, the mean arterial pressure less than 60, reduction in the systolic blood pressure more than 40 millimeters mercury from the baseline. So these are risk factors. The recommendation is that laparoscopy is favorable method in most patients, especially those with age less than 70, symptoms less than 24 hours, no shock, perforation smaller than 1 cm, and a Boy score of 0 to 1. In this study, the issue is to whether laparoscopic repair is capable of reducing the risk of post-operative morbidity and mortality in patients with high Boy score needs further evaluation with a larger population. In all our patients, as long as hypotension was corrected preoperatively, patient is optimized prior to surgery with available expertise and facilities. Higher Boy scores should not preclude patients from laparoscopic repair. Perforation less than 2 cm based on the WSES guidelines suggests performing primary repair. There was no recommendation made whether the use of an augmental pad can provide further protection from the repair. Those with equal or more than 2 cm, they recommended a tailored approach based upon the location of the ulcer. Remember, for large gastric perforated ulcer, always suspect malignancy and do a frozen biopsy. About 10 to 16% of all gastric perforations are caused by gastric carcinoma. For stable patients with large gastric ulcers that raise the suspicion of malignancy, they suggest resection with contextual operative frozen section. In case of a large duodenal ulcer, repair plus or minus a pyloric exclusion or external biliary drainage only in extreme circumstances. Large perforations poses a high incidence of recurrence of leak, so a re-leak post-repair. when repair was performed laparoscopically. So it's usually technical or inadequate patching or the loosening of the sutures after the edema subsided. In all our cases, we do biopsy of gastric perforation and perform classical omental patch repair, followed by H. pylori eradication. Preoperative endoscopy as a diagnostic procedure was said to be contraindicated for perforation. This is due to the fear of spreading intra-abdominal infection in patients with peritonitis. However, some would attempt as long as there is no free under the diaphragms or in an upright chest film and who is clinically stable to rule out other pathologies. So this is an example of an 84-year-old female, a 40-pack-year smoker with an osteoarthritis, chronic osteoarthritis, chronic intake of NSAID for 20 years. So patient came in hypotensive but was resuscitated. So once you go in, you check on the entire abdomen, suction first, all visible purulent collection. So this could be a gastric content or a bowel content. Check for all areas with purulent collections. So aspirate as much as you can. After the aspiration, you can now proceed and find the source of this abscess. This is your gallbladder. So the port placement is on both mid-clavicular line, the upper abdomen. You can see how the fibrin have formed. So this is more than 2 days already. You can see on your right is a huge gastric perforation at the antrum. That is your gallbladder. So this is your falciform ligament. You can see a huge gastric perforation around 2 to 3 centimeters. You can see the edges are somewhat irregular with a probability of malignancy. However, in this situation, this is a septic patient. Even if this is a malignant, you need to temporize and wait for the patient to become stable. So we usually get biopsy, frozen section for this kind of ulcers. So that is already your duodenum, the first portion of your duodenum there. You can see there are some areas, questionable area of lesion. So we cut part of the wall and send it to frozen section. Luckily, it turned out negative. So for this large perforation, you cannot really attempt closure because of the edema and the tension that you will get. So we usually repair this using an adequate amount or a large amount of omentum. So usually we fashion, we really get a part of the omentum and transpose it in this area. So usually 3 around okay, so we are using this is an absorbable O suture. So after the patching, we continue decontaminating the peritoneal cavity with copious NSS irrigation. And then we try to remove as much as we can the fibrin collection. So as you can see, it can be easily removed. So those that will be hard to remove, we can just leave them. But as long as you can remove them, it's really nice to remove them. So this part of the diaphragm, be careful in the manipulation or the removing of the fiber in this area. You might perforate the diaphragm. So until everything is clear, then we put drain after. So usually this large ulcer, we delay the oral feeding until we are sure that the repair is sealed and there's no perforation. Another patient, 70-year-old male with a minimal peritonitis but with a pneumoperitoneum on chest x-ray. So also a smoker and NSA, chronic NSA user. See small perforation, less than 1 centimeter. So this perforation can be closed primarily. So usually even if we can close this primarily, we still patch, we put omentum over the repair. But in all our practice and all our patients, we use classical omental patching. So we just put the omentum and close it over the perforation. So some recommend sutureless repair. So actually, we do not practice sutureless repair. So I believe that those who do not want suture would do a non-suture repair, but the chance of re-leak is very high. So there's even if you pour a lot of glue in that area, you will expect leak within the same admission. So the margins, this is the reason why most of our repair are classical omental patching, because most of the patients you will see have edematous and friable lesions, and the patients are actually with comorbidities. So you want to go out fast, so don't need to close and then you patch. So the easiest way to go out is finish the procedures, just put the patch and suture the patch, the omentum over the perforation. So this is a very bad perforation. As you can see, it's in the area of the stomach and the first portion of the duodenum. This is a complication of a severe pancreatic necrosis. So I'm just showing it to you because even in this worst situation, omental patching will really help. So most would probably do pyloric exclusion, a more complicated procedure, and you can see the entire abdomen is edematous. So we put the mental patch, and because of the location, it's in the first portion of the duodenum, we added a drainage procedure, gastroduodenostomy and truncal vagotomy this patient. So the patient went well, without leak, without reoperation, and the patient was fed on the 4th day. After the repair, endoscopy would really help to check for the patient, also to assess if the repair is good or if there is something in the stomach that needs to be addressed, like if there's a mass that needs biopsy, and if there are other pathologies that you missed during laparoscopy. So, in summary, non-operative management can be offered in selected few with strict inclusion criteria for both appendicitis and perforated peptic ulcer disease. Laparoscopy offers an excellent advantage over complicated appendicitis. The strict indication for PPU should be considered considering the limitations of laparoscopy and the expertise. Follow decontamination principles to decrease the chance of persistent sepsis. Thank you everyone and good afternoon.
Okay, thank you, Dr. Ong, for nice two lectures on appendicitis and PPU. Is there any questions from the room? Yes.
Hello, doctor. I would like to ask, how do you think is the appropriate diagnosis rate in the acute abdominal state to a surgery doctor? Thanks. The diagnosis rate.
Again, please.
You mean the diagnosis rate of what?
Acute appendicitis.
By laparoscopy?
And when in the diagnosis using the CTs or using the image examination.
你是说用 CT 来诊断 ？Okay. I think the question is how to diagnose.
Final diagnosis 就是你开完之后，你确定它真的是阿片的那种诊断率这样。如果有时候好像是开进去，它不一定真的是阿片这样，就是那个诊断率应该是几 % 是合格的。
Okay, so I think the question is, yeah, you understand? Is like when you go in with laparoscopy, sometimes it's negative appendicitis, and so when like how diagnosis it's not always evident with the CT or blood tests, clinical signs. How do you diagnose accurately? Make sure that when you go in with laparoscopic, you don't like go into a negative appendicitis.
Yeah, so absolutely that's a very important question because not all diagnostic imaging tests would give you 100% diagnosis. And even if we are sure clinically that this is an acute appendicitis, it could be another problem if we go in. So most of the tests now, that's like the recommendation, physical exam plus ultrasound will give you a 97% chance of diagnosis. And CT scan will give you around 98 to 99% with a good technique and sometimes the expertise of the one reading it. Sometimes there is an equivocal finding even if you exhaust everything. So that will now be dependent on the clinical assessment or the expertise of the surgeon. Because there are cases that even if there is an equivocal finding in all the diagnostic tests, the persistence of the symptoms warrants surgery, then I would do diagnostic laparoscopy. So for diagnostic laparoscopy with direct visualization and with your experience in laparoscopy, you can actually diagnose acute appendicitis almost 100%. But sometimes when the finding is equivocal and it's not consistent with acute appendicitis, you will find something in the abdomen, but not related to acute appendicitis. So in our country, tuberculosis is quite common. That's why the presentation is almost the same as acute appendicitis, but these are more more on a chronic presentation. So sometimes the reason for going in is just for diagnosis and getting a biopsy. No? So I think the experience of the surgeon has a very important role in these cases.
Okay. So I think because we have some young doctors here, so how to diagnose appendicitis is also very important because some etiology like TB is very common in Philippines and not so common, but sometimes also we can see it in Taiwan. The same presentation as appendicitis, like right lower quadrant pain, fever, and but could be maybe for 2 weeks. So when you see a patient in the ER with like abdominal pain, history and physical exam is very, very important. And so there's many clues that can give you like a guess. And other diagnoses like inflammatory bowel disease, like Crohn's or ulcerative colitis or diverticulitis of the right side can also be looking similar to appendicitis. So when you go in, there's nothing wrong with the appendix. Then you feel, oh shit, very bad. So you want to avoid that. But we all did that, I think, in the beginning. But and also for any other questions on appendicitis? Okay, or PPU.
Okay. Thank you for Dr. Ong for a wonderful speech. And I have a small question about the PPU section. When you have demonstrated the video, the first case is a really big also perforation, and you have suspect that it might be the malignancy, and you just take the frozen and close the wound. And I'm thinking about if you would try to perform the hemigastrectomy or even the subtotal gastrectomy in the first place, or just repair the wound and wait for the final frozen and then perform the definite diagnosis. Yeah, and that's my question.
So, yes, okay. So remember, these patients have a lot of comorbidities. This is an emergency surgery, and the patient came in with hypotension, with signs of sepsis, and you can see the abdomen. There are a lot of fluid collection, abscess collection in the peritoneal cavity. Doing a definitive surgery at this time will give you more problems. So the less that you address the problem, just patching it for a meantime, and anyway, the biopsy, the frozen section turns out negative. So if, for example, this is malignancy, so there's a result of cancer in this patient, I don't think during this time a definitive surgery is possible. So you can close the patient, talk to the patient that the finding is like this, explain that the definitive plan is doing a hemigastrectomy. You can actually do it on the same admission once the patient is stable. So you prepare the patient well so that you won't be in a hurry in doing the surgery, especially if it's a cancer surgery.
Yeah, so usually we don't do, even if it's a cancer, we never do like a proper cancer surgery, because you need a big you need a hemi gastrectomy or subtotal, and you need lymph node dissection, and the patient is in a bad condition. So if you do all this, it will be very dangerous. So I stopped doing, actually for me, I stopped doing biopsy, because because even if it's positive, you don't do the cancer surgery. So usually, if it's easy to biopsy, I take a small piece. If it's bleeding and I just don't do biopsy, I just close it and then return to do biopsy by endoscope. And even if you do take a small piece, you don't need the frozen, because you can do a permanent pathology, which is easier for the pathologist, because even if it come back, the answer is positive, you're not going to do anything anyways. So so it's also interesting that your strategy is omental patch for every hole, but you try to close the hole and then put the patch, or you just put the patch?
No. I just put the patch.
Okay, and try to...
No repair. Yeah.
No repair. So you leave the hole and then just put the patch. Okay, and anybody have experience with
Sorry, I have the question. And if you just put the omentum patch into the hole, is there any cases that would have secondary leak? Because it feels like not that secure for me to just put in the hole.
So that's the same question I had when I was still doing it in my early practice. If I don't prepare this, I might experience a leak. But we are lucky that in all our repairs, we never encountered any re-leak with our technique. The main trick there is to have an adequate amount of omentum that covers enough the defect, the perforation, and make sure you secure the edges, you close you put your suture at the edges. You make sure you have covered the borders and adequate bite, at least around 0.5 to 1 cm from the edge of your defect. So as not to have a cut through sutures. So I think it takes practice to be comfortable in that repair, because I believe some would not want leaving a perforation, just putting a patch. That's why they wanted to do a primary repair. But usually, if this is edematous, there is a chance that it can leak again. No? But in my practice, I do not do a primary repair. I'm comfortable with my technique.
Good. And even for like a large perforation, like 3 centimeter, you just put a patch and cover it?
Yes.
Okay, good. Because it's good because for a big perforation, it's very hard to bring it close. It's very fragile, it cuts through, and so it's a good technique. I tried it a couple times, but usually for very small. If it's quite big, I still try to close it as much as I can, but it's very difficult. And also there's a chance of leakage because if very high tension around the sutures. Okay, so any other questions? 网络有没有问题？没有哈。Okay, so thank you, Dr. Ong. For your information, we have constantly about 220 people watching from Facebook. So it's a lot of people enjoying your lectures, and thank you for your lectures, and hope everything is okay in Philippines and you can come visit us again. Okay, thank you.
Thank you, Wayne, for this opportunity.
Yeah, bye-bye.
Stay safe.
Bye-bye.
See you soon.
Thank you. See you soon. Bye-bye. 好，那我们今天的 session 就到这边结束哈。那刚刚有一些问卷，请大家帮忙填写一下哈。对于今天的 lecture 部分，给我们一些意见回馈。那明天的。